Hello and welcome. I'm Dr. Rini Paul. I'm a GP in Islington and one of the QMEC teacher development leads. For the next 15 to 20 minutes, I'd like to think about the clinical reasoning process with you, what you're thinking, how you make clinical decisions, the processes and the reasoning behind them, why we do things, but also how that links to errors. So by the end of this mini lecture, we should have a common language that we can use when it comes to thinking about theory, specifically the dual processing theory. Maybe explore a little bit about the differences between novices and expert clinicians and how they make decisions. And as I say, really focusing on errors and strategies to reduce errors in our thinking and our reasoning to improve patient safety. So what do you think the key components of clinical reasoning are? I'll give you a moment to jot those down. I would highly recommend the ABC of Clinical Reasoning book by Cooper and Frayne. It's really accessible and relevant to students, educators and teachers alike. Clinical reasoning is underpinned by knowledge and starts with the discussions we have with patients, including our communication skills and clinical skills. We might then choose to use diagnostic tests, and it's important when we're interpreting them to remember there's no perfect test which is 100% sensitive and specific. For example, in patients with lung cancer, 1 in 4 chest x-rays will be normal. In patients with pancreatic cancer, 1 in 10 scans will be normal. So we've got to be aware of false negatives, and if a result is normal but we're worried about the patient, still referring them on. We'll talk a bit more about cognitive biases and very briefly at the end focus on shared decision making, specifically thinking about the patient at the centre of this in evidence-based medicine. The whole way through, we'll really be thinking about our clinical reasoning processes and getting you to think about them, so your metacognition. Here's a quick quiz. What does this show? And this. So these images should be fairly straightforward diagnoses for most GPs. The first is a typical shingles rash and the second is molluscum contagiosum. As students, you may not be exposed to these before, and so you may not recognise them. What does this image show? And this one. What could be the potential diagnoses here? The third and the fourth images are less straightforward. There are a number of different possible explanations. So how do those pictures relate to the dual processing theory we're going to discuss now? The dual processing theory was described by Daniel Kahneman, and he wrote about it in his book Thinking Fast and Slow and won a Nobel Prize for it. So a patient presents, we recognise the pattern instantly and we're in system 1 thinking. This is fast and automatic because we've had experience of this before. We've got a bank of illness scripts, we recognise it almost instantly. We might want to ask a question or two to confirm the diagnosis, and then that leads fairly swiftly onto a management plan. If we don't recognise a pattern, we move on to system 2. This is slower and deliberate and effortful. We have to ask more questions. We have to think about what's more likely. We slow down, and actually we're less likely to make errors here, although we can still make errors here. We're more likely to come up with a differential diagnosis rather than a diagnosis, but can still go on to a management plan. So system 2 is conscious, deliberate and analytical, and we make over 2,000 decisions a day, mostly in system 1, but this diagram makes them look quite linear, and actually we flit in between the two, the gut sort of system 1 thinking and the slower system 2 thinking all the time. So let's think about the factors influencing clinical reasoning. You make clinical reasoning and decisions in real life context. So part of it is about the knowledge or our knowledge gaps, thinking about the reasoning process, which is what we're doing here, and our reasoning skills, helpful to practice those in nice safe environments with your peers and a facilitator where it's not high stakes. But how are you feeling on the day? Are you feeling stressed or worried or anxious? You're aware of those things. And as I say, what's the larger context? Is it under a stressful exam condition, or actually is it with your peers where you're happy to make mistakes and learn? Let's think a little bit next about the types of errors we make. 2/3 of errors are cognitive, so have some sort of human error factor, either knowledge gaps, misinterpretations, cognitive errors and biases. 19% are related to systems errors, so problems with equipment and communication, ambiguity or confusion. And in 7% of cases, even with the most experienced of clinicians, errors can't be avoided. It was something that would have happened regardless. So it's worth bearing in mind, even the most experienced of clinicians will make errors. A study looking at post-mortem data showed that the diagnostic error rate was 10 to 15% for experienced clinicians. Errors, however, are not randomly distributed, and we systematically trend to err in the same direction, so they may potentially be predictable and possibly preventable. Factors that contribute to error. Let's look at the 3 C's: clinician, case, and context. And these can occur in isolation, or they can all converge together and overlap. We've talked a bit about how the clinician might be feeling, about their knowledge, but also they might be overloaded that day. We'll talk a bit more about cognitive biases shortly. The case, the patient, could be someone with a really complex problem or an atypical presentation or multiple comorbidities, someone who is uncooperative because they're confused or imbibed alcohol. And we've also talked about the issues with the context, organisational issues or faulty equipment. Cognitive biases are subconscious deviations in judgments, leading to distortion and inaccurate judgments and interpretation. More than 100 have been identified. And whilst we don't think it's helpful to know every single one of these, actually it's sometimes quite helpful to look through them and try and identify your own cognitive biases. An article demonstrated a while ago that common biases in younger students and trainees tended to be anchoring bias and premature closure. So anchoring bias is where you place undue emphasis on early salient features in the consultation and therefore may not hear or place enough emphasis on information that comes later on, and you might end up seeing what you want to see rather than what's actually there, which is ascertainment bias. Premature closure is accepting a diagnosis before fully exploring other possibilities. So questions that are helpful to ask yourself: have I reached this diagnosis very quickly? Has the diagnosis been suggested to me by someone else? Did I just accept the first diagnosis that came to my mind? How do I feel about this patient? Do I dislike them? Might that impact on my decision making? Have I considered other systems other than the most obvious one? So someone who's anemic, for example, and breathless could also still have a PE. Was I significantly distracted or interrupted whilst I was assessing this patient? Could I have missed something? Do I need to go back? So let's think a bit more about debiases strategies. What actually helps to try and reduce and minimize error? You might have ideas of your own, but here are some that we've discovered in the literature. So using structured data acquisition or checklists like surgeons do, like NHS 111 callers do. Questioning yourself all the time, especially your first impression if you jump to a diagnosis quickly. Slow down, reflect, either on your own or with a group. maybe even with the patient. Get more information. Have you ruled out the worst case scenario? If there is an opposite diagnosis, have you considered it? Have you asked the questions that you can to exclude it? And question yourself again. It's also very healthy to question others. Just because it's someone very senior doesn't mean they're right or that their diagnosis or clinical reasoning process has been accurate. But of course, when we're all stuck, it's worth us putting our heads together, utilising our colleagues and our experts when we're unsure. So let's consider a strategy for exploring your clinical reasoning. We've used the Lynn model, which was from Australian family physician, and we find it really helpful. Consultation 1 is probably what a lot of GP teachers do with you anyway. You'll sit and watch them consult with a patient, and then afterwards you'll have a debrief about the thought processes. Ask them, why did you do that? Or can you explain to me your rationale so that I can understand how you made that decision for my own learning? Consultation 2 is similar with a GP tutor taking the lead, but is more interactive. It's using the stop-start technique and asking the learner what they're thinking. This can be done live, but it's probably best with simulated patients or using very carefully selected patients. We use it in your small group work on your campus days with our simulated patients, with our actors. And finally, what you'll hopefully be doing as well in your simulated group work is where you as a student will take the lead and the clinician will interrupt you at certain points to check what your reasoning is, and then you've got the group as a sounding board to check their reasoning too. So the facilitator will be prompted to stop you at various points, usually sort of suggested with suggested discussion points throughout the consultation. For example, stopping you right at the beginning after the patient has told you they're presenting complaint, getting you to consider what you already think might be going on, whether you have an idea of what the three most likely hypotheses are, what questions you want to ask, and then asking some of those questions, maybe getting your colleagues to help you with what questions need to be asked, and then refining your diagnosis, and then thinking next about your physical examination and relevant investigations. So this is just a reminder that clinical reasoning doesn't just stop at a diagnosis. Watch your GP tutors as they use guidelines with patients and look at those guidelines and see if you think they apply to your patient. If your patient is 95 and has multiple comorbidities, was the population that the guideline is based on relevant to your patient? You'll see your GP tutors use prediction and risk calculators such as Q risk and Wells scores to assess the risk of DVT, and in Q risk the risk of cardiovascular disease. Try and talk to patients about the risks of various treatments and investigations. So there are a number of shared decision-making tools and websites. I've included just two here. On the risks and benefits of HRT and statins so that patients can really understand the information in a user-friendly way, in a way they understand and can therefore weigh up and make their own decisions. So I hope you found that useful. I'd really encourage you to think about your own clinical reasoning processes, especially in groups, combining that with feedback and reflection on how you're thinking. Have a think about what you've learned today and how you'll use this. I'll leave you here with the references and a further reading list. Thank you for your time today.